Recording now.
Hello everyone, and welcome to this webinar sponsored by Suicide Prevention Australia. My name is Darryl Higgins. I'm the Director of the Institute of Child Protection Studies at Australian Catholic University. And I'd like to begin by acknowledging the traditional owners of the lands on which we are meeting and which you are all meeting on today, and pay our respects to elders past, present and emerging. Today we are going to be speaking about a rapid evidence review that we conducted of effective interventions to reduce suicidal thoughts and behaviours among children in contact with child protection and out-of-home care systems. And I'm speaking with my two colleagues, Sebastian True and Douglas Russell, also from the Institute, and they'll be sharing with you the insights that we gained from that rapid evidence assessment. So I'm going to begin by asking you, Seb, to tell us a little bit about when investigating the role of risk factors associated with childhood trauma and interactions with the child protection and out-of-home care system play in suicide and suicide-related behaviour. What key factors did we find in the rapid evidence assessment?
Thanks, Darryl, and hi everyone. Well, our first key finding found that factors for suicide, as we identified in the general population, overlap in almost all aspects with characteristics of children in out-of-home care.
And what are those key characteristics, Seb?
Well, we saw that the psychosocial factors contribute most to the suicidal risk profile in children and young people in the general population. And some of those significant factors included psychological factors such as depression, anxiety, drug and alcohol use, and comorbid psychiatric disorder, and along with a history of harming. The other main factor was stressful life events, which included family problems, peer conflicts, bullying, all forms of abuse, but in particular sexual abuse and suicide or attempted suicide of a family member or peer. And then finally, personality traits. So neuroticism, impulsivity, self-esteem, and in particular resilience. So we found that of great significance, the strongest risk factors for suicidal behaviour among children and young people are the major psychiatric problems, including depression, substance abuse disorder, and sexual abuse in childhood.
Thanks, Seb. And what about the risk factors for children coming in contact with the care system, with child protection and out-of-home care systems?
Yeah, so the key risk factors we identified for contact with child protection systems included parental substance misuse, poorly treated parental mental health issues, and family violence. In addition, Aboriginal and Torres Strait Islander children are significantly overrepresented, with this year reported as 8 times as likely as non-Indigenous children to have received child protection services. The intergenerational vulnerability was also an important factor, with parental out-of-home care experience a risk factor for removal of children. And children in out-of-home care, we found, are typically subject to multiple placements, placement breakdowns, including instability of placements.
So Seb, what are the characteristics of children in out-of-home care then that overlap with some of those risk factors that you were identifying before for risk of suicide?
So when we then mapped the studies reporting on trauma outcomes of children and adolescents residing in out-of-home care systems to the established psychosocial factors that contribute to the overall suicide risk profile in children and adolescents in the general level population, so we observed, specifically in Australia, that children in kinship and foster care had exceptionally poor mental health and socialisation. Caregivers reported 53% of children in home-based foster care needed professional help for their mental health problems, but only about 27% had obtained help during the previous 6 months. We also found 50% of children in out-of-home care reported with clinical depression and anxiety, and many also appeared to have considerable difficulty forming bonds with adults, such as carers who might act as a parent towards them. In addition, we found nearly 7% of young people aged 13 to 17 years in home-based foster care reported a suicide attempt that required medical treatment during the previous year. Overall, children in out-of-home care have a higher than average levels of drug and alcohol abuse. And those children who have experienced traumatic life events have a higher risk of detrimental outcomes linked to substance abuse issues as well. As well as experiencing a range of harm types that triggered entry into out-of-home care, children and young people are also likely to be placed in multiple out-of-home care placements and exposed to workers and services in sometimes reported inappropriate or unsafe homes, or returned back to the caregivers who initially perpetrated some of the abuse in some instances. In addition, about 4.9 young people in care, about 4.9 times more likely to commit suicide than young people without a history of child protection. So, and a lot of these findings were also consistent with other areas we looked at internationally, such as the UK, the US, and some places in Europe, such as the Netherlands.
So Seb, having covered those commonalities of risk factors for entering the care system and risk factors for suicide, is there any indication from the literature that you've reviewed as to what may be beneficial for supporting children and young people who are residing in care, particularly residential care, but also foster and kinship care, in terms of addressing suicidal behaviours and thoughts, and the possible role of out-of-home care in that situation?
Yeah, definitely. So as well as finding a lot of literature that identified many of these factors and then considered the overlaps, there were some key suggestions to help minimize the potential role of out-of-home care as a risk factor. And primarily that was seen as an organization-wide trauma-informed care models, which at this point in time are suggested as likely to be beneficial. But when we were looking at specific interventions that could effectively reduce suicidal thoughts and behaviours of children and young people in care, we came across some interesting findings, which our colleague Douglas, I'm sure you'd love to share with us now.
So Douglas, yes, can you tell us a little bit about what the programs were that you found that met our criteria of addressing suicidal behaviour or risk of suicide in the care population?
Sure. So what we did was we looked systematically through the literature to identify any studies that investigated suicide interventions in samples of children who were in out-of-home care. And we didn't limit that to residential care. We included, we were very broad in our search strategy. Interestingly, we only found two. So two studies globally that had investigated how to prevent or reduce suicidal thoughts and behaviours in young people in out-of-home care. One of those, again, going back to what Seb was saying about the risk factors for entering out-of-home care, was actually a study on young girls who in the US had been referred and put into out-of-home care as a result of their own delinquent behaviour, which sort of isn't the standard. Normally, young people are going into out-of-home care as a result of family breakdown and issues in parenting. So, if we were to say discount that, we only found one study that's looking at the risk, the suicide intervention efficacy with what we would think is a standard out-of-home care population.
And in terms of the approach that both of those interventions take, can you still tell us a little bit about the kind of nature, if you like, of the interventions?
Sure. So the two interventions were quite different. The one aimed at, in the US, at the girls that were in out-of-home care as a result of their own delinquent behaviour was called using multidimensional treatment foster care. And effectively what that is removing the young person from an environment where maybe their delinquent behaviour isn't being addressed and trying to support that person to develop skills and to be less involved in delinquent behaviour. And at the same time, that study did look at how that sort of treatment supported a reduction in the risk for suicidal or in suicidal thoughts and behaviours. The other study, which was done in Spain, which was a more standard out-of-home care population, which was young people in the government's care, used emotional intelligence therapy. And again, going back to what Seb was saying, that study wasn't purely aimed at reducing suicidal thoughts and behaviours, although that was something that it measured. It also looked at the basic psychological needs of the young people that were involved in out-of-home care. And that already is a good sign that even though we only found 2 studies, both of them are already looking more holistically at the biopsychosocial needs of the children, looking at their psychological needs, looking at their behaviour, and seeing how that complex interaction of all of the different things that might be acting as a risk factor for suicide could actually be addressed through the one intervention.
And Douglas, what do you think is the role of training for those who are working with young people in the care system?
That's a great question, because one of the things we did find when we were going through the literature systematically was that there were a number of studies that were coined gatekeeper training. And effectively what they were studies that looked at the efficacy of training up staff or carers who work in an out-of-home care system to have the knowledge and skills to prevent suicide. What wasn't done as part of any of those studies that we found was actually measuring the suicidal thoughts and behaviours of young people. So while they may be effective in, while those gatekeeper trainings may be effective in increasing the knowledge and skills of the participants, the carers, and the workers within the systems, whether or not that's actually reducing suicidal thoughts and behaviours hasn't yet been assessed and evaluated. So there's definitely some things that, going forward, we would recommend as a result of the review that we've conducted.
Thanks, Douglas. So in terms of those recommendations, it's very clear that what we need to do is to adapt, implement, and also better evaluate those adaptations of the kind of clinical interventions that already exist that target suicidal behaviours in the general population, and to address those in the specific context of out-of-home care, given that there are so few targeted programs that are designed specifically for an out-of-home care population. I think that it's really important for us to also remember, given the findings that Seb pointed out, that because so many of the risk factors for being in the care and protection system overlap with the kind of risk factors for suicide related behaviours, we know that there's likely to be significant benefits if we are able to roll out trauma-informed and trauma-focused interventions within the out-of-home care system. Because we know that significantly the young people who are in out-of-home care have experienced harm already, as Douglas mentioned, likely to be at the hands of parents and other caregivers prior to having entered into care, and are often at continued risk of harm while in the care system. And so those kind of trauma-informed models of care that deal with the consequences of child maltreatment and other lifetime adversities right across the period of early childhood, middle childhood, and adolescence, to be able to have targeted interventions that address those consequences of maltreatment themselves will be reducing the risk factors, the known risk factors for suicide, given what Seb has just outlined as the very high level of overlap between those two. We also know, though, that we don't just need one set of interventions. We probably need to have them tailored and adapted to different contexts. So in Australia, we know that Aboriginal and Torres Strait Islander children are overrepresented in the child protection and out-of-home care system. And so therefore, for interventions to be effective, they're going to need to be culturally appropriate and informed by Indigenous knowledge systems and tried and tested, if you like, during that phase of either developing new culturally appropriate or culturally adapted versions of other programs. And similar stories emerge in terms of other migrant or culturally and linguistically diverse populations who might have different contexts of their own trauma experiences that need to be addressed in those interventions. And the final point, given that we did a rapid evidence assessment of the published literature in the grey literature and also the peer review journals, what we know is that there's actually very little published in this space. And so one of the key recommendations is that as new programs are developed or adapted, that they are rigorously evaluated and those results are disseminated so that internationally we're able to share best practice around how we can reduce the risk factors within the known population of children and young people in out-of-home care and deal effectively with the consequences of the harm and the trauma that they have already experienced so that they don't continue to be at higher risk of suicide and suicide-related behaviour while in the care of the state. If you want to learn some more, we have a full report based on the findings that we have described today, and there is also an infographic which has a brief summary of the key messages, and they're available from the links associated with this webinar recording. Thanks for your time, and we wish you all the best in your endeavours to provide a better and safe environment for children and young people. Thank you.